Yes, thank you so much. We have many classifications. As I said, like first time Rockwood, like put forward is first time shoulder classification. Then we have the most commonly used Thomas and Medicine classification, which says like traumatic, that is the TURPS and the AMRI. But the only problem with this classification is that it says the most of these traumatic shoulder instabilities like are bidirectional, but that is not the often case. So we need a more specific classification, and we often see that there is a abnormal muscle patterning in some group of patients, and sometimes we have unidirectional instability instead of the bidirectional. Then we have the Gerber classification. He tried to mention these voluntary shoulder dislocations, and also he mentions that this MDI may result because of the single traumatic event instead of the traumatic microtrauma. So it is very it is very important to have normal glenohumeral rhythm as far as the function of the shoulder joint is concerned. And we know that the scapula contributes a lot to the glenohumeral motion. Yeah, and the scapula has to rotate in a particular fashion against the chest wall. And there should be an upward rotation and inter-rotation as well as the upward, as well as the extra-rotation of the scapula in order to have a full range of movements at the shoulder joint. As far as the stability of the shoulder joint is concerned, we know that we have the static stabilizers and the dynamic stabilizers. The static stabilizers, they provide the static stability. And most of the mid-range stability and the end-range stability comes from the rotator cuffs. In the end-range stability, the rotator cuff tried to protect the capsule and the ligaments by preventing the extreme degrees of shoulder movements. And in order to work this static and the dynamic stabilizers, what we know that it is very important to have a normal shoulder proprioception pathway, that is the sensory afferent pathway and the efferent pathway. And most of all this together works on the basis of the concavity compression mechanism. So what is concavity compression mechanism? It is the force exerted by the resultant force of the rotator cuff exerted against the effective glenoid arc. So that is the concavity compression mechanism. Now coming to the Stanmore triangle, Stanmore from 1983 to 2003, they did the dynamic electromyography in most of the shoulder instability patients, and what they found is that there is some abnormal muscle patterning or abnormal muscle activation in some group of patients. And depending on the history, clinical examination, and the investigations, that examination under anesthesia, imaging, orthoscopy, and the functional EMG, they classified these patients into three polar groups. The polar group 1 is, that is a traumatic structural, that is a TURPS. In polar type 2, usually it results because of the trauma or maybe less trauma or microtrauma. And most of these patients have some kind of a structural lesion, although may not be very significant. And this polar type 3 is mostly non-traumatic and non-structural, and it mainly includes the patients with the predominant muscle abnormalities or the activation. So coming to the polar type 1, usually it is a traumatic and a unidirectional. We know the most common instability pattern is the anterior, which is more common in almost more than 90% of the patients, and the posterior, which is far less. Also, it is very important to look for these instability severity index, which is put forward by Professor Baulu. And what we know that it is very important to know the age of the patient, associated laxity, level of sports the patient plays, and also the glenoid and the humeral bone loss. So what we know that if all these factors are present, there is a very high risk of the recurrence in this group of patients if we do only a soft tissue repair. And also with the chronicity or with the, if you don't treat such kind of patients in the very early stage, there is a risk of progression of the labral tear, which ultimately results into the extended Bunkart lesion or the global tear, and sometimes there is a plastic deformation of the capsule, which ultimately results into the multidirectional instability. We have mainly three types of the shoulder laxity. That is the congenital one, which is most commonly associated with severe forms of the syndromes and the connective tissue disorders. Then we have the constitutional laxity, which is very common in the generalized population, although these patients may not be symptomatic or may not be, they may not have any pain or the subluxations. But what is important here is the acquired laxity, which is very common in the very high-end athletes or sometimes in the gymnastic, and it may result because of the repeated trauma or the stretching of the capsule. So it is very important to look for the Beighton score. We know that the score of more than 4 out of 9 is associated with generalized joint laxity, and often laxity is only a clinical sign, and it is not a symptom, and instability is a symptom. So this laxity of the shoulder is commonly associated with the MDI. We know that Neer first time used this concept of multidirectional instability. So coming to the polar type 2, that is a traumatic structure instability. It typically occurs in the very young patient, that age less than around 25 years. It has an insidious onset, and the underlying cause is the repeated microtrauma or stretching of the capsule. Scapular dyskinesia is very commonly associated with this form of instability. And in a very late stage, we often see the overactivity of certain peripheral muscles, that is the pectoralis major and the latissimus dorsi. So it is very important to look for the laxity of the shoulder in such patients, and also look for the instability, direction of instability. In the MRI, we often see that absence of the structural lesion or a minor labral tear, but most commonly it is associated with increased capsular volume, or sometimes a hyperplasia of the labrum and the capsule. So the main difference between this polar type 2 and type 3 is the absence of structural lesion on the MRI scan. Now coming to the polar type 3, that is a traumatic non-structural muscle patterning. So usually there will not be any history of trauma. There will be absence of structural lesion on the MRI scan, and there will be a abnormal, inappropriate abnormal muscle activation in this patient. And the most common or the most prevalent form of the instability is the posterior functional shoulder instability, which is very well explained by the Philip Moder in 2017. And the main pathology is the weakness of the infraspinatus muscle. So we know that the rotator cuff is very important shoulder stabilizer. And what happens if there is a reduction in the rotator cuff forces? So 50% reduction in the rotator cuff forces results in the increased anterior displacement of the humeral head by almost 45%, 46%, and the posterior displacement of the head by 31%. This Anju Jaggi and Ian Bailey published a paper, and they found that there is a inappropriate muscle activation, inappropriate muscle activation in the pectoralis major and the latissimus dorsi in this MDI group of patients, and they found that in the anterior shoulder instability, the pectoralis major and latissimus dorsi is overactive in almost more than 50% of the patients, and in the posterior, although the pectoralis major is a little bit less active than the latissimus dorsi. So this is a cadaveric study from Joan Labriola and Thekuli, and they found that with a decreased infraspinatus activity and the increased pectoralis major activity, what happens? So if there is a decreased infraspinatus activity, there is a significant decrease in the compressive forces by almost 30%. And with the increased pectoralis major activity, the compressive forces increase by 12%, but the main deforming force is that there is a significant increase anteriorly directed forces by almost 1200%. So that is very significant, and probably that is one of the main pathology in this polar type 3 group of patients. So role of deltoid in the glenohumeral stability. Lee and Ann, they quantified the contribution of the deltoid in the glenohumeral stability based on its compressive and the translation forces. And what they found that if there is a shoulder abduction in the scapular plane, the deltoid acts as a shoulder stabilizer. But if there is a shoulder abduction in the coronal plane, it acts as a shoulder destabilizer. So this may have a role in the rehabilitation of such group of patients. So this is the scapular dyskinesia, and we know that scapular dyskinesia is very common in this group of patients. So it is very important to look for this scapular dyskinesia and how the scapular dyskinesia acts, because it makes the cuff ineffective by affecting the length tension curve relationship of the rotator cuff muscles. So Paul and Ludwig, they studied the three-dimensional shoulder kinematics between persons with a MDI and in the asymptomatic controls, and what they found that there is a significant decrease in the scapula upward rotation, and there is an increased scapula interrotation or the decreased scapula exrotation. So this is my case. Actually, I came across this patient. He's a 27-year-old male patient, engineer by profession, and he is symptomatic since last 2 years. So I will try to play his video. So he's having this kind of a problem since last almost 2 years, and he did the MRI scan 1 year before, and now this is the problem. Now so I look for the laxity of the shoulder. Here you can see here this gauge hyperabduction test was positive. And there was a anterior and the posterior test was also positive.
Dr. Gorgile, we have
yes.
1 minute.
Yes, and what he typically shows me that there is a depression at the junction of the acromion and the humeral, and we call this as acrohumeral step up, and this may be because of the inferior sagging of the humeral head. And I did the X-ray. This is the X-ray with the 5 kg weight. We can see that there is a inferior subluxation of the humeral head, and this is the MRI scan. And surprisingly, actually, what we found that in this patient there is a posterior labral tear and there is a posterior paralabral cyst also, and there is some mild retroversion of the glenoid. I came across another patient, very young 15-year-old male boy, and he is having this problem since last many years, and one of his relative came across and his parents could not able to recognize this problem. And see this? Yes. And this is his MRI scan. MRI scan was almost normal with a mild retroversion of the glenoid, and the labrum was completely intact. There was no any other significant pathology. So what are the treatment options? So as far as the polar type 1 is concerned, the surgical repair or reconstruction of the soft tissue and the bone is very important. But it is very important to consider some factors before going for surgery. So I will look for the instability severity index, and also I will look for the on-track and the off-track lesion before deciding the kind of surgery I want to do. As far as the polar type 2 is concerned, we know that many papers, they showed a very good results with the conservative treatment, that is the physiotherapy for 3 to 6 months. The only indications for surgery in such group of patients are if the patients are symptomatic or if the MRI scan shows a significant structural lesion. What kind of operations we can do? We can do either NINS open capsular sheath procedure, but nowadays we do arthroscopic capsular application with the closure of the rotary interval and the repair of the structural lesion. As far as the traumatic non-structural polar type 3 is concerned, we know that it is mainly because of the weakness of the infraspinatus. And Philip Moder, they did a study and they found very good results with the shoulder pacemaker, and they found that the recovery time is also very less with the shoulder pacemaker as compared to the physiotherapy. And these are the factors, that is increased glenoid retroversion, glenoid dysplasia, and the posterior scapulohumeral decentering is associated with the recurrence of the instability in this group of patients. So thank you so much, and I will try to take any questions if you have.